Chers amis, chers collègues, bon après-midi. Je voudrais remercier le comité organisé pour son invitation dans ce grand pays et ces grandes conférences. Je vous remercie, Dr. Mohamed Zidi, pour cette invitation. My talk will be en français, en anglais. Mais en français, c'est pas très bon, elle est mauvaise. Management of submacular hemorrhage, traitement les hémorragies sous-maculaires. Je m'appelle S Elbaha, I'm professor of ophthalmology at Alexandria University. It's the first time for me here in Morocco. Thick submacular hemorrhage can cause sudden loss of vision in patients with age-related macular degeneration. There are a lot of causes which leads to this submacular hemorrhage, including AMD, high myopia, macroaneurysm, and others. If we lead this hemorrhage under the retina, there is a loss of problems which may occur. First of all, the iron which is present in the hemoglobin lead to have a toxic effect on the retina. The shearing force of the photoreceptors by the fibrin clot contraction, separation of the photoreceptors from the RPE, it leads to great danger, acting as a barrier in nutrition supply. Submacular the hemorrhagie sous-maculaire petit, large, and grand. According it is within the arcade, reaches the arcade, or beyond the arcade, it may reach till the equator. It may be thin, 500 micron, or thick, more than 500 microns. There are methods for treatment, including observation, anti-VEGF injection, intravitreal gas with TPA and without TPA, and photodynamic therapy. Surgical removal with or without the TPA. We have here a case of extensive submacular hemorrhage at the beginning or in the early days. The treatment is to go under the retina, and by doing a temporal retinotomy and flip the retina upside down and go under the retina and try to remove this hemorrhage and this membrane. Il faut tenir with pens. And at the end, we have to put the retina back in place and do laser photocoagulation. Macular translocation is another way of treatment. Another new treatment is pneumatic displacement of the submacular hemorrhage. In this treatment, it should be medium-sized hemorrhage, it should be thick, and should be at least the maximum 6 weeks. More than 6 weeks, we couldn't make this technique or do this technique. Here is a case of submacular hemorrhage. We start at first with injection de TPA, tissue plasminogen activator. It leads to liquefaction of the blood. After that, we inject air. The air monté en haut and the hémorragie en bas. Okay. And at the end, we do fluid-air exchange. The fluid-air exchange acts as a brake. It prevents this air to monter en haut. It remains as it is in the macular area. Here is a case. We have two main tools for this procedure. The first one is the TPA or tissue plasminogen activator, 25 microgram per 0.1 mil. We inject around from 0.2 to 0.5 mil. And it is usually by the cardiologist and neurosurgeon. Here is my first case, 70 years old man with visual acuity 1/6, with the angiography of the case, as we can see, and post-operative, the patient improved. And here is a colored photo, 0.3 vision, and here is a fluorescein of the case. Marvelous improvement. Another female, 65 years old, visual acuity 260, presented after 3 days of the submacular hemorrhage. Here is the colored, and there is OCT. As you can see, there is a new vessel C, and the fluorescein angiography of the same case. The most important is the use, the second most important is the use of this cannula. It is a 41G cannula done by a Dark company. It has a soft tip, it is expandable, you can push it forward and backwards so you can go under the retina and inject what do you like. It's very important to use this way. This case, this is the same case of the female. I am using the twin light. Twin light give us an excellent visualization. Start by vitrectomy. And after that, as we can see, the pulsations of the optic nerve, and there is a huge hemorrhage extending to the fovea and extending beyond the arcades. After vitrectomy, we go inside with this 41G cannula, and we have to select an area away from the fovea. It should not go through the fovea. It's better to be inferior and close to the disc as much as possible, just a penetration, and you start to inject the TBA very slowly, very gradually. Avoid rapid injection, strong, powerful injection. It may lead to foveal through. And so, as we can see, there is sensory détachement, décollement de la rétine ici, dans cette partie. Okay? It's very important that you have this sensory detachment of the sensory retina. After that, you start to inject the air, and should be few bubbles of air and should be very slow. The TPE you injected will do liquefaction of the blood, and the air will lead to displacement of the blood inferiorly. At the end of the procedure, I have to inject it, do fluid air exchange, and ask the patient at the end of the surgery to take sitting position so the air go up and make the brake to stop the air which is present subretinal to travel superiorly. This is a case at the end of the, this is before, this is a case after 1 week, 2 weeks, 3 weeks. As you can see, there is complete displacement of the hemorrhage inferiorly, and the vision of the patient improved dramatically in few days. This is an OCT of the same case. As we can see, complete resolution of the hemorrhage of the case. Here is another case. The same procedure is done. You have to select an area away from the fovea and go very slowly and start to inject the TBA under the retina and do fluid air exchange. Okay, this is my first talk about pneumatic my second talk is choroidal patch graft in myopia. Choroidal neovascular membrane, as we said before, have different management, starting by anti-VEGF injection, medium macular hemorrhage. We can do the procedures we have said before about pneumatic and submacular injection. Huge hemorrhage, you can do, as we said, surgical excision. I'm going to proceed for autologous transplantation of retinal pigment epithelium and choroidal free graft. It was first proposed by Payman in Ophthalmic Surgery Journal 1991. And this is my case, a 67-year-old lady, one-eyed patient with visual acuity 50 centimeters. It is the only eye. And I proceeded for this technique. This technique is somewhat difficult, but it is the only way in certain cases. As you can see here, we'll proceed by vitrectomy. You should remove the vitreous until the posterior hyaloid face. After that, il faut faire le décollement de la rétine avec le 41 cannula. You can go in different places to be sure that you did a complete separation. After that, fluid air exchange. The fluid air exchange push the subretinal fluid posterior so you have a complete detachment of the retina. Temporal retinotomy. avec les diathermy and the vitrectomy. Then I inject perfluorocarbon below the retina, sous la rétine. And il faut tenir les new vaisseaux avec le pince. Il faut faire ça doucement. In certain cases, you may have hemorrhage from this site, from the origin. You can use diathermy at this part to stop this hemorrhage. Sometimes this membrane is very tough and very difficult to remove. After removal, the retina pigment epithelium is denuded in this area, so we have to take another retina pigment epithelium and the choroid. I'm using the upper temporal part of the retina. We start to delineate this part of the choroid with the diathermy and the laser. And avec les ciseaux, il faut couper le choroïde doucement and faire attention pour l'hémorragie. After that, start to pull on this choroidal patch. It is a choroidal patch with the retina pigment epithelium. You are pulling to its final destination on the macular area. There are very important rules. The most important rule, not to flip it upside down. The retina pigment epithelium should be, the pigment epithelium should be to your side and the rest of the choroid posterior. I'm spreading it. You can spread it with the Thanos scraper. Then after that, I have to put the retina back, and this is by injection of perfluorocarbon inside and aspirate the perfluorocarbon sous la rétine. I'm aspirating le PFCL sous la rétine doucement, so not to allow this graft to move from its place. Complete removal of the PFCL sous la rétine and injection to PFCL sur le nerf optique, and this is the part where the choroid harvested. Laser photocoagulation as usual, silicone perfluorocarbon exchange, and silicone injection. Here is the case after surgery. As you can see, complete removal of the membrane. This is the reflection of the silicone bubble which is present. The fluorescein, this is the part of the graft which is implanted inside. This is the OCT post-operative. The vision of the patient reached 20/200. She is very happy actually. The indication for this technique by exudative AMD, failure of other techniques, patient didn't have any other surgical choice. Why choroidal patch graft? Excision of the subretinal membrane didn't result in visual improvement due to damage of the outer retinal layers. Dragging the graft doesn't curl or flip upside down. The PFCL is high density, it doesn't coat the graft. The PFCL in the subretinal is not toxic. The PFCL flatten the graft with good apposition and confirmed centration. The most important and crucial and essential, c'est la perfusion de cette graft. Perfusion of this graft. It should have a perfusion from choroid. Otherwise, will be nonsense. And perfusion takes from 1 week to 3 days. This is a case, and this is the first week, as we can see, no perfusion. On the 10th day, start perfusion here. On the 23 weeks, more perfusion. After 60 days, more infusion of the graft. And this is very important for the success and the improvement of surgery. Retina pigment epithelium, peripheral RPE and central RPE have the same function. It doesn't differ. Here's the case with, as you can see, this is the part where harvested the graft, and this is the place of the graft, and this is the angio. The size of the graft should be at least 3 to 4 disc diameters to allow appropriate handling of the graft. The visual outcome, if you retina pigment epithelium cornea graft in patient with detachment results for 7. Here is a study for 133 patients underwent this technique. 5% of these patients have visual acuity more than 20/200. It's been more than 660, and 5% of the patient has visual acuity from 20/40. One patient achieved 20/32. This is not my study. This study was done somewhere else. Thank you for your attention.